This video I'll demonstrate how to do a phacoemulsification in a patient with poor pupillary dilatation and the kind of pupil which doesn't respond to mydriatics. Although this can be done using pupillary expansion devices, but here the issue is to demonstrate it doing without them. So this is the patient who was supposed to have this kind of pupillary dilatation and a significant cataract and was scheduled for cataract surgery. This is the fundus photograph. It shows minimal haze and tessellations as can be expected with the aging process. I must mention that this is a minimally edited video just to give the correct flavor to the viewers regarding what goes on during such surgery. So this is the patient. We can see this is the size of the pupil. This is something like 2.5 millimeter in size, and this is a pre-marked knife which can help in deciding what is the incision length. So a keratome entry has been made into the anterior chamber, and first of all we'll attempt to dilate the pupil using injection phenocaine. This is available. This is a tropicamide plus phenylephrine which can aid in pupillary dilatation during the surgery, and as we can see there's some help which has been achieved and the pupil has slightly dilated more, and this can be attributed to probably a higher concentration which is delivered. Second goes the intracameral injection of lignocaine with injection adrenaline. So the concentration is 0.5% lignocaine, and we can see the pupil has slightly dilated and now it is something like 4 millimeters in size. Now we are proceeding for the capsular excess, and as you can see the pupil is not very well dilated, and we will aim to have a capsular excess of at least 6 millimeters in size. And such a scenario where the pupil is not dilated up to the mark, the excess has to be done nearly blindly, and just by intuition you have a slight idea where the excess advancing edge is, and you use these clues to make our excess which is done blindly, but it is large, and we can see it has been done. So once the excess has been done, one has to make a side port, and this side port knife when it enters will invariably hit the iris because iris is in the way and the pupil is not dilated. However, when the pupil is dilated, this is not the situation. Doing hydrodissection is again a purely blind procedure, but one can touch onto the cortical matter and inject the fluid, being sure that it is deep into the cortex and rather not above the nucleus, above the capsule. We can see the pupil is constricted slightly, which is not going to be very good for us. However, we will proceed with the phacoemulsification, and I must mention that the other eye also has been operated and had a similar problem. However, in that eye we had a softer nucleus, and this was operated about a year back. So now proceeding with the phacoemulsification, and we can see the irrigation path is slightly turned towards the cornea, which is aligned back so that the flow of the fluid infusion line is not towards the corneal endothelium. Removing the overlying cortex and then going for the direct horizontal chop. Again, the issue is that one has to approach up to the equator of the lens and then squeeze or lacerate the nucleus and separate the pieces. So here we can see this has been done, and it's a full thickness chop, and we now rotate the nucleus. And during all these maneuvers, it is very important to have a very good foot switch control and a machine which can provide a stable chamber. Any amount of surge may cause further problem, especially aspiration of iris is very common because iris tissue is very close to the tip, and it may flow with the fluid flow into the aspiration tip. Once the iris has been aspirated, it will invariably get traumatized, and if by mistake phaco power is turned on, then that is going to shaft the iris. Although they are not very detrimental for the final outcome, but it is desirable not to cause damage to the iris tissue, and so that the patient's eye is as good as normal. after the surgery. Multiple chops are done, and these chops are done more or less intuitively depending on the tactile sensations and experience as has to be there when performing such a situation. Once the nucleus pieces are adequately chopped and they can be seen to get mobilized, one can simply proceed to pick up each one of them one by one and bring them to the pupillary area in the center and emulsify them. Those pieces which are large can be again re-chopped, taking care that the iris tissue is not touched, and this phacoemulsification is performed at the pupillary level. The control has to be good, and every activity has to be done in the center of the pupil. You cannot afford to go to the periphery where not only that the things are not visible, but also the lens tapers and the PC rises up and your safe working space is constricted further. We can see half of the nucleus and more has been removed, and one can see now the nucleus is completely gone. One has to make sure that every possible bit of nucleus is removed, and here we can see the epinucleus is engaged, lifted up, deformed, and then consumed in the center. One has to be very sure that none of the iris tissue is aspirated in this process. Now what we are left behind is just peripheral cortex, which will be removed using irrigation aspiration cannula. Every possible break should be used to replenish the viscoelastic gel, which will provide good coating and protection to the corneal endothelium and keep the chamber formed. I am ready with my Y-shaped dialer, and this is used to expose the tissue behind the iris by retracting the iris, pushing or pulling it. But here I was able to make out the wisps of cortical matter just behind the pupillary border, so I have not used this tool and just kept on engaging the fibers of the lens which are visible just behind the pupil and keeping track of all the quadrants which I have finished, so that I can sweep all the quadrants and none of the quadrants the cortex is left behind. This is the subincisional area, and this also has been cleaned, and then once it is determined that the cortex has been removed, it is the time to implant the intraocular lens. Now this is a preloaded lens, but I could see that the tip is not getting accommodated and the IOL was busted out of the tip, and then I realized that this tip is meant for 3.2 mm incision, so a new tip was used, and this is a thick IOL because it is 26 diopters. Probably that is why the company had provided a thicker tip so as not to break the IOL, but with a gradual and very controlled fashion I was able to inject this IOL 26 diopters using a standard 2.8 mm disposable cartridge. The trick is being slow and deliberate and allowing the IOL to get deformed so that there is no breakage of the optic or the haptic part. Once the IOL has gone inside, it is time to dial the IOL because the leading haptic is settled in the bag and the trailing haptic can be simply dialed using a dialer. These are important steps so that you have an IOL in the bag, and this has to be confirmed because any IOL which is not in the bag can be a future cause for irritation and uveitis. Now the surgery is nearly finished and this portion is being run at 2.5 times the speed to remove the viscoelastic gel. And here we have successfully completed this case in which the pupil was extraordinarily myotic and without use of any mediatic device. This is the day 1 picture, and we can appreciate the patient is doing fine, and at this moment the patient vision was 6/12 best corrected. Thank you.